Introducing the all-new EU Funding and Me app. The app that transforms the way you search, manage and make the most of your EU-funded projects. Combining the thousands of opportunities on the Funding and Tenders portal with the ease of use of a mobile application. Save your searches, bookmark your favorites, and never miss a deadline, event or news item thanks to personalized notifications. Boost your knowledge through funding-related news and info days with in-depth information and insights. Coordinating EU projects? No worries. The app makes it easier to reach out and stay connected. So, if you have an idea, Eureka, download EU Funding and Me.
Okay, so we're ready. And we'll just dust off this little interruption, because what we're doing now is one of our rapid fire talks or elevator pitches or what you want. And well, I guess everybody who's doing so are nice and warm and ready and had the time to do a second rehearsal. So we're going to hear from 4 more cancer mission projects now that are focused on clinical implementation. We will move on to Dr. Patelli. There you go. Hi. Are you ready? Is that okay? We didn't ambush you now with this? Okay. So Dr. Giorgio Patelli from Sagittarius, Precision Adjuvant Therapy for Colon Cancer. And take it away.
Thank you so much.
Thank you.
So on behalf of the Sagittarius Clinical Network, I'm pleased to introduce a project that brings precision medicine into the everyday management of colon cancer. As you know, every year in Europe, 100,000 people are diagnosed with colon cancer. This is a serious issue. And most of the cases are actually resectable by surgery. However, as clinicians, after surgery, we usually treat these patients with adjuvant chemotherapy to reduce a statistical risk of relapse, even though most patients are already cured by surgery already. And having this same treatment for all the patients is not good enough, is not good for people, is not good for healthcare systems. And Sagittarius, as you see here, is meant to change this. We leverage a simple blood test, liquid biopsy, to trace tiny fragments of tumor DNA circulating in the blood after surgery. And these can now inform us whether residual microscopic metastatic disease is present in that patient or that other patient, so we can distinguish residual disease. And therefore, when the blood is negative, we assume that patients are very likely cured by surgery already. When the blood is instead positive, then the risk of relapse is very high. And the game changer is thinking whether we can avoid overtreatment with toxic chemo in those patients that are already cured by surgery, liquid biopsy negative, while tailoring treatment in those that are instead in need. Of course, with the aim of improving quality of life and reduce financial toxicity. And, well, Sagittarius is exactly doing that. This is a large European randomized phase 3 study enrolling patients with high-risk stage 2 and stage 3 colon cancer. It's based on liquid biopsy, and it's actually 2 trials within one, because on one end, we focus on patients who are liquid biopsy negative after surgery, and we de-escalate chemotherapy. We avoid chemotherapy over treatment. On the other hand, we tailor treatment for those in need, the liquid biopsy positive, who may benefit for more innovative drugs, like targeted agents or immunotherapy that are part of this trial. And of course, the clinical endpoints are relapse, survival, safety, and quality of life. Sagittarius is a network of 9 European partners and 26 participating hospitals across Europe. it's not only a trial. We are building a platform, a translational platform to deconvolute the biology of micrometastasis and possibly to finally explain why some tumors do relapse and others do not, and of course to bring innovation being more accessible and equitable. And Silvia Marsoni, you see her here, is the person, the scientist that is coordinating, who has coordinated this great effort together with other minds that share a vision of cancer genomics being mixed with clinical research toward a unified patient solution. And in the end, I must say, I think the goal is pretty clear. We want to make adjuvant treatment for colon cancer and patients with colon cancer smarter, less toxic, and of course, more individualized. Thank you very much for your attention.
Thank you. And I'm so sorry that there was a bit of a noise from there. I think these people are working very hard to fix our technical problems. They somehow have to communicate to do so. Collaboration, you know. Okay, I think we actually fixed our little audio problem now, and we do have a connection ready to Dr. Febe van Maldegem. Good afternoon, Dr. Febe van Maldegem. Are you there? Yay, we can hear you and you can hear us. Oh, only me? You have to turn that up a bit. We need higher volume. Hello? Okay. Okay, Dr. Febe van Maldegem, we're working on the volume now. I can actually hear that there's some kind of audio getting through, but it's very meager, so we need to be able to hear. Okay, should we, while you fix that, proceed with, I think that's a better idea. We'll proceed with Maya Clevel. Is that okay, Maya? Are you ready for this? Okay. Sorry to ambush you as well on this. I hope that's okay. So here's Maya from Care 1, European Study on Metastatic Kidney Cancer Treatment from Gustave Roussy. Ready to go?
Yes.
Take it away.
Thank you, everyone. So today I'm here to present to you the Care 1 project, which is a project funded by the EU. So Care 1 is a first-line randomized study platform to optimize treatment in patients with metastatic renal cell carcinoma. Yes. So the project is focused around the pragmatic clinical trial. This is the overall study design of this trial. And so we are looking to improve the lives of patients with treatment-naive clear cell metastatic renal cell carcinoma, which is the most common form of kidney cancer. We're looking at patients with a poor prognosis under 5 years. And these patients will be stratified according to the PD-L1 status. PD-L1 is a biomarker that we will look in the tumor cells of these patients. And we will stratify them in either PD-L1 positive populations, which are the patients where we will find at least 1% of the PD-L1 biomarker in their tumor cells, and the PD-L1 negative population. At the beginning of the trial, we estimated that around 30% of these patients would be PD-L1 positive and 70% PD-L1 negative. We are looking to enroll 1,200 patients in this ambitious pragmatic clinical trial. And then we will randomize them to receive either one of these two combinations of therapies. So it's either a double immunotherapy, which means 2 immunocheckpoint inhibitors, or a combination of an immune checkpoint inhibitor, immunotherapy, with a tyrosine kinase inhibitor. What is the goal that we aim to accomplish? Today, the standard of care is to use either one of these two combinations, but the clinicians don't have a decisive biomarker or guideline that states which one of these combinations would be the best appropriate for a given patient situation. So we believe that PD-L1 would be a great biomarker that would be able to determine which of these combinations would be best used in PD-L1 positive or PD-L1 negative patients. And that way, the overall goal of this is to improve the overall survival and the progression-free survival of the patients. As you can see, this is a very ambitious program. We have a lot of partners that are working with Gustave Roussy and the project coordinator, which is Professor Laurence Albigès. And as we said, this is an European project with the goal is to have impact in the lives of cancer patients. And so one of our main outcomes is to hope to improve the patient lives and looking at diagnosis and treatment by implementing this routine biomarker for these patients, but also to look to improving diagnosis and treatment through several other aspects in different work packages. So for example, in work package 2, we will be looking to improve pathological diagnosis using new digital tools and artificial intelligence tools. In work package 3, we're working closely with patients towards better health data reporting tools. This means developing new health data apps to accompany the patient to the treatment, as well as quality of life questionnaires adapted to their treatments. We're also working with a cost-effectiveness study and automatized data extraction with AI tools as well to optimize the use of the health resources. And in work package 5, we're developing a rich translational research by preparing an imaging database and a lot of blood samples that we're collecting from these patients for exploratory research in renal cancer. And so, as we said, this is an international project. Today, the trial is ongoing. We're enrolling already in 7 countries. We have more than 58 participating hospitals that are recruiting patients in this trial. We've achieved more than 25% of the expected enrollment needed for the trial. And soon we should be joined by other countries as well. And we look forward to sharing the results. And thanks to the EU.
And I just noted that Denmark was on there. So are you meeting up with some of your future research colleagues there?
Not today, did not have the time, but yes, we should be joining us in early 2026.
Oh, exciting, Denmark. Good for you.
Thank
you. Let's applaud the 2 presentations that we've already had. And this is a very laid-back conference, so we're going to take another break now. We need a break now. 6 minutes of presentation. Oh, we're good. Drop the break. Okay, so I think we are gonna, the good thing about this, Dr. Febe van Maldegem, is that you have the longest name in the entire conference. Of now I've said it maybe 11 times. So
can you hear me now?
Yes, we can, and we're so happy. I think everybody's applauding. So let me just repeat, Space-Time, the project Space-Time, spatially decoding lung cancer. And one last time I'm going to say Dr. Febe van Maldegem, and now I'm going to give it up to you. Take it away.
Thank you. Thanks for the organizers to give me the opportunity to pitch our project here. Do you also see the slides?
Uh-oh.
Different challenge. So I'll start with the talking already, and then hopefully...
Describe the slides with your words. I'm going to give you extra time. We're not going to pause it again.
I'm the coordinator of Space-Time, and Space-Time stands for Spatial Analysis of Cancer Evolution in the Tumor Immune Microenvironment. Next slide, please. So Space-Time is an EU mission cancer project within the cluster of understanding tumor host interactions. And we've been running about a year and a half now, almost. It's a consortium of 15 European partners, a total runtime of 5 years, and we have a budget of 12 million euros. And our mission is to define spatio-temporal tumor microenvironment signatures to be used as the basis for precision immunotherapy in lung cancer patients. And I will explain in my next slide what we mean with the spatio-temporal tumor microenvironment signatures. But in simple terms, our aims are to generate a necessary understanding of lung cancer to be eventually able to select the right immunotherapy for the right patient. So the research will be focused on both space and time. And with space, we mean looking at the spatial characteristics of the tumors. We want to learn how the tumor cells interact with the immune cells and stromal cells in the tumor microenvironment. And to achieve a comprehensive understanding, we will be using molecular imaging techniques by which we can deeply profile the tumors. We can determine which cell types are there, are they activated or inhibited, and what other cells do they interact with, and who are their neighbors. In this way, we will be looking for recurring patterns in which we can find these cells organized in the tumor tissue. Secondly, we incorporate the sense of time by including patient samples of all stages of the disease, from carcinoma in situ to advanced metastatic disease. To get a better understanding of the early stages of lung cancer, we will use mouse models to look at tumor initiation and pre-malignant stages. So the imaging of tumors across these different stages of the disease will allow us to understand how recurring cell neighborhoods develop over time. So looking at the co-evolution of the tumor with the host, the patient. The outcome of the project will be that with these spatiotemporal profiles, we will be better able to predict the course of the disease, better understand the impact of risk factors, and develop biomarkers to predict therapy response and resistance to help guide us to select therapies, so going towards precision medicine. And with that, I'd like to thank you for your attention.
Thank you. Okay. And moving on to Dr. Marie Bernkopf. Oh, here we are. Hello, Dr.
Yes,
Bernkopf.
can you hear me?
Yes, we can.
Awesome.
From the
Perfect.
Mona Lisa Project, liquid biopsy monitoring of childhood neuroblastoma. And Dr. Bernkopf, are you ready?
I'm ready, yes, and I see my slides.
Excellent. Go ahead.
Okay, so it's a great pleasure and honor to present to you Mona Lisa, which is the first trial that prospectively evaluates liquid biopsies in pediatric cancer, and it's also the first one that will base clinical decision-making on liquid biopsies. And so the center of the project is a pragmatic clinical trial where we will randomize 150 patients with relapsed neuroblastoma into either the standard follow-up monitoring or the standard follow-up plus monthly liquid biopsy testing. And those tests will be performed on only 5 ml of peripheral blood, and we will use innovative and sensitive assays, so a combination of mRNA and cell-free tumor DNA testing. This testing will be performed in 7 reference labs that are compliant with the EU in vitro diagnostic regulations, and we will also provide training and guidelines for future labs. Furthermore, we will link the results to clinical databases for future pediatric cancer research. We will develop a clinical decision support tool, and we have already developed the Mona Lisa app, which you can download with the link here, where we will measure patient-reported outcomes and quality of life within the trial. Next slide, please. And so, next slide. And so, thank you. And so we've decided to improve very specifically the monitoring for neuroblastoma because it's the most common solid tumor in infants. It accounts for 50% of cancer-related deaths in children, and more than 60% of patients suffer from a relapse or progress within a year. And then only 10% of patients are cured, and this is despite a very high intense treatment where the response evaluation and the standard follow-up is currently done every 3 to 6 months and involves nuclear imaging, where these little children need anesthesia for as well, and bone marrow response assessment. So we are convinced that liquid biopsies are a better and less invasive marker. And we can be so convinced because of our previous work, where we could also show that we could detect relapse up to 17 weeks prior to clinical presentation. Next slide, please. And when I say we, I mean actually the Mona Lisa consortium and all 25 partners from 11 countries involving psychologists, biologists, statisticians, and the whole neuroblastoma research network. Next slide. And here you see a group picture. And we all work together improving the outcomes for children with cancer. And with this, I'd like to highlight the Mona Lisa video. Next slide. Which I hope you watch and share. With that, I thank you for your attention.
Thank you very much, Doc. I'm always already lost in my own papers here, Dr. Bankov. Sorry about that. All right, so we're ready for the next panel now.